MDS, as you know, is related to AML, is often a precursor to AML. And some of the changes have related to the borderline between MDS and AML. And one change the ICC did make is introducing a overlap category that was felt to be in between MDS and AML. That is, patients that have 10 to 19% blasts or MDS increased blast 2 in the WHO 5th edition classification. And the reasons for this, I think, were multiple, but partly because I think this is an area that needs further study. It's unclear whether these patients are better approached as AML or MDS. And I think the ICC felt that recognizing this group would enable at least some of these patients perhaps to be more appropriately treated as AML, and some may be more appropriately treated as MDS. They may depend on their genetic background, on their tempo of disease, on the history or how the disease evolved over time. So I think that's an area that needs further study, and also some uncertainty in counting blasts, which is somewhat arbitrary, and putting any rigid threshold to define a disease is always going to be somewhat arbitrary. So I think, recognize that the division between MDS and AML is blurred, and I think the MDS AML entity introduced by the ICC is in kind of recognition of that. And other changes that the ICC made and also were made by the WHO are to introduce new genetic categories of MDS, a low-risk type MDS defined by SF3B1, and on the other side, a very aggressive type defined by P53 mutations, similar to as I mentioned earlier, the introduction of P53 mutated AML in the ICC. And I think the idea of those is to more accurately, I think, define MDS based on the genetic features. I think those were important changes that were made. And I think the idea is that with the ICC making these changes, that we'll be able to diagnose MDS more precisely and give better guidelines to clinicians that are managing these patients.